Welcome to urinalysis. Urinalysis and body fluids. In this class, the first three units will consist of different factors relating to urine and the urinalysis, and then the final unit, Unit 4 in this class, we will be covering just a lot of different topics and pretty much just everything that we would examine other than blood or urine. So that would be various different types of body fluids. We're going to cover a section on metabolic diseases and kidney disorders. So the last unit is a bit of a mix. In this first unit, we're going to talk about just kind of the introduction to the process of a urinalysis, some renal function, and then the urinalysis, that procedure itself is divided up into kind of three sections or three categories. So this first unit will be on the physical examination of urine. Second unit, we will cover the second step in the urinalysis procedure, which is the chemical analysis of urine, which involves all of the tests that are on the urinalysis dipstick. And then in unit 3, we get into the microscopic examination of urine. Okay, so first unit, we're talking just kind of an intro to urinalysis. So analyzing urine was kind of considered to be the beginning of laboratory medicine. There's been references found in hieroglyphics. Cavemen and Egyptians examined urine for color, clarity, odor, viscosity, sweetness, and they examined it for sweetness by observing that certain specimens attracted ants or tasted sweet. And then the same characteristics are reported today, but we've also added that chemical and microscopic examination also. Hippocrates wrote a book on what he referred to as uroscopy, and during the Middle Ages there was a lot of effort by physicians put into uroscopy. Chemical testing for glucose and protein was developed, and then there were also charlatans called pisse prophets that threatened the credibility of the urinalysis by offering what they called their interpretation of urine, and of course this was for a hefty fee. But that process led to the first medical licensure laws in England in the 17th century. And then the invention of the microscope in the 17th century led to examination of urinary sediment, and the urinalysis became part of a doctor's routine patient examination in 1827. So urine is an easily obtained specimen that can provide valuable information about the body's major metabolic functions, and it's a fairly inexpensive test. It's very common. I'm sure probably every one of you listening to this has probably given a urine sample for a urinalysis at some point in your life. So the CLSI, which is Clinical Laboratory Standards Institute, defines a urinalysis as the testing of urine with procedures commonly performed in an expeditious, reliable, safe, and cost-effective manner. So why do we perform urinalysis today? So it aids in the diagnosis of disease. It can screen asymptomatic populations for undetected disorders and to monitor the progress of disease and effectiveness of therapy. So it can aid in diagnosis of disease. So if a doctor thinks, okay, this condition is what's occurring in this patient, the urinalysis, along with other parameters, will help in the diagnosis of that disease, and can screen for asymptomatic populations. So a lot of times urinalysis can be used kind of as a precursor or an early detector of certain diseases. So even though the patient may not be exhibiting symptoms yet, we can use it as an early indicator for certain diseases. And then, of course, to monitor progression of disease and effectiveness of therapy. So an example of that would be maybe patients who have recurring UTIs. We can monitor through those urinalysis results. Is this therapy effective at treating and preventing future UTIs. Okay, so urine formation and composition occurs in 4 steps. The first is filtration, then reabsorption, then secretion and concentration. And we're going to go through each one of those steps. So that kidneys continuously form urine as an ultrafiltrate of plasma. Reabsorption of water and filtered substances essential to body functions converts about 170,000 milliliters of filtered plasma to what becomes our average daily urine output of about 1,200 milliliters. Urine consists of urea and other organic and inorganic chemicals dissolved in water. So urine is normally 95% water and 5% those other solutes. There are considerable variations possible in those urinalysis results based on the individual patient. So that could be due to dietary intake, physical activity, body metabolism, endocrine functions, and even body position. The major organic solute in urine is urea, which is a metabolic waste product formed in the liver from the breakdown of protein and amino acids. It accounts for nearly half of the total dissolved solids in urine. Some of the other organic substances in urine are creatinine and uric acid, which are elements that identify a fluid as urine. So can you think of a situation when that might be helpful, that you would have to identify a fluid as a urine? Drug screens. So this happens somewhat frequently in the lab, you get a sample for a drug screen, but you look at the sample and you question whether or not the sample is truly urine. So it's so light in color maybe that it looks like water. So you question the validity of that sample. You can run on the chemistry analyzer a test for creatinine and uric acid, and if neither of those substances are present in the sample, then you know that it is not urine. The major inorganic solid dissolved in urine is chloride, followed by sodium and potassium. And then dietary intake greatly influences the amounts of these compounds found in urine. So it makes establishing normal values very difficult just because there can be so much variation. Other substances found in urine include hormones, vitamins, medications. Urine can also contain other formed elements that are not a part of the original plasma filtrate. So that includes cells, casts, crystals, mucus, and bacteria. Increased amounts of these elements oftentimes will indicate disease. Urine volume. So urine volume depends on the amount of water that the kidneys excrete, which is determined by the body's state of hydration. So some factors that can influence urine volume: fluid intake, of course. So how much is the patient drinking during a day? Fluid loss from non-renal sources. So that could be through bleeding or vomiting. Variations in the secretion of antidiuretic hormone, and the body's need to excrete large amounts of dissolved solids such as glucose in salts. So if the patient is getting an increased intake or has an increased intake of some of those substances such as a glucose or salts, then the body wants to get rid of it. So it's going to excrete that in the urine. The usual daily urine output is 1,200 to 15 milliliters. So that's what kind of the normal daily output is, but the normal range for output is considered anywhere from 600 to 2,000 milliliters per day. Okay, so a little bit of terminology here. Oliguria indicates decreased urine output in adults. So it is defined as less than 400 milliliters per day. You'll commonly see this when the body enters a state of dehydration due to either vomiting, diarrhea, perspiration, or severe burns. Anuria is when urine flow ceases, which could result from any serious damage to the kidneys or from a decrease in the flow of blood to the kidneys. Nocturia is increased urine excretion at night, where normal urine output is 2 to 3 times greater at night than during the day. And then polyuria is increased urine excretion during the day, defined as greater than 2.5 liters per day, which is the same as 2,500 milliliters per day. This is often associated with diabetes, but it can be artificially induced by caffeine, diuretics, or alcohol. Okay, polyuria in diabetes mellitus versus diabetes insipidus. So diabetes mellitus is caused by a defect either in the pancreatic production of insulin, which is referred to as type 1 diabetes mellitus, or in the function of insulin, which is also referred to as insulin resistance, which takes place, that's the hallmark of type 2 diabetes mellitus, otherwise known as adult onset. So this results in increased glucose concentration. So there's going to be an increased volume of urine seen due to the body's need to excrete the excess glucose that the kidneys do not reabsorb. So patients will exhibit polydipsia, which is excessive thirst. And although the urine appears to be dilute, the urine will have a high specific gravity, which is just a measure of like the particles found in a solution, because of that increased glucose content. With diabetes insipidus, this results from a decrease in the production or function of ADH, which is your antidiuretic hormone, so that the water necessary for adequate body hydration is not reabsorbed from the plasma filtrate. So in this case, urine is truly dilute and it will also have a low specific gravity. These patients are also going to exhibit polydipsia because the body's trying to compensate for fluid loss by greater ingestion of fluid. So it can result in an even greater urine volume. So in diabetes mellitus, the patient's going to have an increased urine volume and an increased specific gravity. Diabetes insipidus, patient's going to have increased urine volume, but a decreased specific gravity. And here's just kind of a visual on that concept if you want to look through that. Okay, specimen collection criteria. So containers used for a urine sample should be disposable. They should be wide-mouthed to facilitate collections by female patients. You want them to be flat-bottomed to prevent overturning, and you want them to have a screw-top lid so that they are less likely to leak. You want a clear container so that you will be able to judge the color and clarity. At least 50 milliliter capacity, which allows for the proper amount needed for the microscopic exam. And that also provides additional specimen for repeat analysis, leaves enough room in the container so that the sample can be mixed by swirling. Adhesive bags are available for collecting pediatric specimens, and large plastic containers are available for 24-hour collections. And I will make one little note about 24-hour collections. You have to, depending on the test being ordered, for that 24-hour collection, the patient may have to obtain multiple 24-hour collections because different preservatives are in those containers based on the test being ordered. So if the doctor wants one test that requires one type of preservative and another test that requires a different preservative, that patient's going to have to collect 2 separate 24-hour collections. Okay, specimen labeling. At the very least, all samples should be labeled with patient's name, ID, date, and time of collection. Some additional information that can be included with the sample includes the patient's age or date of birth, location, and the healthcare provider's name. Also, the label with the patient information must be attached to the container, not the lid. And that is because, if you've got, say, 5 urine samples, set up on your workbench to perform testing on. You take the lids off of all of them. If those lids were to get mixed up for some reason, then you don't have the actual specimen itself labeled. Okay, the requisition form, which is the form that has the tests to be performed indicated on the piece of paper. So this must accompany the specimen. The information on the requisition has to match the information on the sample. So if the patient's name as it's written out on the form does not match the patient's name on the sample, or the date of birth doesn't match, or the social security number doesn't match, anything like that, all of those are causes for rejection if the information does not match. And then some additional information that can be included on the requisition: method and time of collection, possible interfering medications, patient's clinical information. Of those parameters, the method and time of collection is probably the most important to us in the lab, because that can affect different testing that we perform. Okay, specimen rejection. And each lab is going to have kind of their own written policy for what's acceptable and what is non-acceptable for specimens. So they're going to each have policies for rejection. An unlabeled container, that's going to be standard in any lab. If you receive a specimen in the lab, whether it's urine or blood or anything else, if it is not labeled with that patient information, then you can discard it. You can reject that specimen. Labels that do not match between the label and the requisition. So as I just mentioned on the previous slide, if you've got a sample that has the name on it Jane Doe, and your requisition says Jane Dale, okay, those names don't match, so you can reject that. Specimens contaminated with feces or toilet paper, contaminated containers, insufficient quantity of specimen received. So we can perform a urinalysis on a very, very, very small urine sample, but if we don't have enough to do any additional testing that's required, then we could reject it as quantity not sufficient. And even, we could even do like a urinalysis, but if we don't have enough to pour over to centrifuge to do the microscopic, we could at least report out the urinalysis results and then just kind of put in comments that quantity was not sufficient to perform microscopic. If the doctor has, multiple tests ordered and we do not have enough sample to perform all of those tests, at that point, I would call the doctor and just kind of let them know what the situation is and ask them to prioritize the testing that needs to be done. What's the most important for this patient's diagnosis, and then I'll do that first. And also delayed or improper transport. So the sample should be transported on ice or kept refrigerated until it's time to transport. So if they're not going to be able to get the sample to us in a timely manner, it has to be preserved, and usual means is through refrigeration. Okay, specimen can undergo a lot of changes that can affect the results if it's not collected and preserved properly. So correct handling procedures are pretty important. The specimen should ideally be tested within 2 hours of collection. If testing is delayed, then the specimen should be refrigerated, or some type of appropriate chemical preservative should be added. And again, that would totally depend on the tests being ordered. There is a table in the book that describes the 11 most significant changes that could occur in a specimen allowed to remain unpreserved at room temperature for more than 2 hours. Most of those changes that occur are related to bacterial multiplication. So if there's bacteria already present in the sample and then it's allowed to sit out at room temperature, then those bacteria are going to go crazy multiplying, but then that bacterial multiplication can lead to other changes in the sample. Some of those changes that can occur include increased color and turbidity, so the sample will get darker and cloudier, increased pH, nitrites, bacteria, and odor, and then decreased glucose, ketones, bilirubin, urobilinogen, red cells, white cells, and casts. Okay, and then there's just a picture of that chart that's in the book that goes through those changes, or the parameters that we test for or report on. What happens? Are they increased or decreased? And then why it's happening. Okay, specimen preservation. So the most commonly used method of preservation is refrigeration at 2 to 8 degrees Celsius, which will help decrease bacterial growth and metabolism. It's essential if the specimen is to be cultured, because we don't want to be, if the doctor's ordered a specimen, a urine culture, but the specimen has been left sitting out at room temperature for a number of hours. We just got finished saying that bacterial replication can occur. So any bacteria that grows on the culture from that sample that's been left sitting out at room temperature is not going to be truly indicative of the patient's state. Should be refrigerated after collection, during transport, and for up to 24 hours. However, refrigeration causes the precipitation of amorphous crystals, so it has to be returned. The sample should be returned to room temperature prior to chemical testing by reagent strips. There are chemical preservatives that can be used when refrigeration is not possible, or if the specimen must be transported over long distances. So the ideal preservative is bactericidal. It inhibits urease and preserves those formed elements like cells in the sediment, and the preservative should not interfere with any chemical testing that is to be performed. So that kind of goes back to what I was saying earlier about the 24-hour collections. The test that is ordered is what determines the preservative that can be used a lot of times. So you want to make sure that any type of preservative that you're using is appropriate for the tests being requested. And really the perfect preservative does not exist. So one should be chosen that best suits the needs of the testing to be performed, or like I mentioned earlier, the patient just may be required to submit more than one sample. Okay, so some different types of specimens. It's sometimes necessary to regulate the specimen collection procedure in order to have a sample that adequately reflects the patient's metabolic state. So to do this, certain aspects of the collection, such as the time, duration, method of collection, and dietary intake, might need to be adjusted. So patients must be instructed when special collection techniques are required. A random specimen is the most common type of specimen because it's the most convenient for the patient. It may be collected at any time, but the time of collection should be recorded on the container. This type of specimen is useful for routine screening tests to detect obvious abnormalities. Because of the fact that diet and physical activity can affect the results, an additional specimen may be requested. So, based on the results that you get from this random specimen, the doctor may want to follow up with a second specimen or a different type of specimen. The first morning specimen is ideal for screenings. So the sample is more concentrated than a random sample, which assures detection of chemicals and formed elements that may not be present in a dilute random specimen. The patient must collect the specimen immediately once they get up in the morning, deliver it to the lab within 2 hours of collection, or refrigerate it if that's not possible. This type of sample is important in preventing false negative pregnancy tests, and it's also important in evaluating orthostatic proteinuria, which is a condition where increased protein is seen in urine only when the patient is in an upright position. Okay, a fasting specimen. I don't think this specimen type is mentioned in the book, but this would be the second voided specimen of the day, so it would not contain metabolites from the evening meal. This type of specimen is used a lot of time in glucose monitoring. 2-hour postprandial specimen. I don't think this one is mentioned in the book either, but this specimen is collected before the patient eats a routine meal. Then the patient eats the meal, and then the next specimen is collected 2 hours after the meal is finished. So this can help to monitor insulin therapy These results would be compared to a fasting urine specimen and to blood glucose test results. A glucose tolerance specimen is sometimes collected to correspond with blood samples drawn during a glucose tolerance test. The number of samples that the patient is asked to collect could vary with the length of the test. And then results are reported along with the results of the blood test and are used to help in interpreting the patient's ability to metabolize a measured amount of glucose and are correlated with the renal threshold for glucose. Next, the 24-hour timed specimen. This is useful when it's required to measure the exact amount of a urine chemical rather than just detecting its absence or presence. So 24-hour specimens are going to give quantitative results versus qualitative results. So this is necessary at times because some solutes exhibit what's called diurnal variation, which means that levels can change throughout the day, as well as variation with meals, activity, and body metabolism. So getting that 24-hour result would be more reflective of the actual amount in the body. There's also a method that can use a shorter timed collection for substances that are present in consistent levels, but that method's not used as often. Okay, collection procedure for a 24-hour collection. The patient must begin and end the collection on an empty bladder. So when the patient begins the collection, the first morning urine should be discarded. Then the patient begins collecting the urine after that first one is discarded. Then the patient begins collecting the urine. And then on the second day, the patient will void the first morning urine and will add that sample to the collection. The collection should be kept refrigerated or on ice for the duration of the collection. And then after being delivered to the lab, if the sample is collected in more than one container, they have to be mixed thoroughly and the volume has to be accurately determined because the calculation of the chemical is calculated and reported based on volume collected within that 24-hour period. So you want to reserve an aliquot for testing. Some tests also require the addition of chemical preservatives, which need to be non-toxic to the patient and not interfere with any of the tests to be performed. So just going back to that volume for a second, like I mentioned, if the patient collects more than one container, most of the 24-hour urine jugs that are made for that purpose are marked on the side. They have like little notches on the side that indicate volume. So you can look at both of the containers and add those together. If for some reason the patient were to bring in a sample that is not in one of those types of containers, you would have to mix the two specimens together in some other type of holding container to measure that volume. And again, you want to make sure that you mix the specimen well before you mix them. Catheterized specimens are collected under sterile conditions by passing a hollow tube through the urethra into the bladder. This is the most commonly requested specimen for urine culture, which should be set up before the urinalysis is performed. And that's just because we don't want to take any chances at contaminating the sample by putting that urine dipstick into the sample before we set up the culture. A midstream clean catch. This is an alternative to the catheterized specimen. It's safer and less traumatic for the patient. It's also less contaminated by epithelial cells and bacteria than a routinely voided specimen. This one is going to be more representative of the actual urine than a cath specimen also. A suprapubic aspiration would be collected by external introduction of a needle into the bladder. It provides a sample for culture that is completely free of contaminating materials. So it can be also used for culture or cytology, which is the study of cells. And then pediatric specimens. So they make soft, clear plastic bags that have hypoallergenic skin adhesive to attach to the genital area on the baby. You want to be careful not to contaminate by touching the inside of the bag when you're applying it. And then you're going to sterilely transfer the specimen to a sterile urine container and label the container. Sterile samples can also be obtained from babies through suprapubic aspirate or catheterized specimens, but you don't want to have to do that to a baby if you don't have to. And then lastly, drug specimen collection. Correct collection procedures and documentation are absolutely necessary to ensure the results belong to the specific individual submitting the specimens. So drug urine specimens a lot of times will undergo a process called chain of custody. So that's the process that provides the documentation of proper sample identification from the time of collection to the receipt of the lab results. So it must document and accompany every step of the drug testing, from the person who collects it to the courier who delivers it to the lab personnel who performs the testing, to the medical review officer, to the employer. So those samples have to be able to withstand legal scrutiny in a court of law. So it's necessary to follow the sample from beginning to end to provide or to prove that no tampering occurred. So if a patient were to come into the ER with, say, their diagnosis is altered mental status, the doctor's probably going to order a urine drug screen. In that situation, chain of custody is not required. If a patient hurts themselves on the job, and this is going to be, say, a matter of workers' compensation. So that's something where, you know, the company, the employer, is going to want to make sure that all of that chain of custody was followed before they pay out benefits or whatever. Or chain of custody is oftentimes used for pre-employment drug screening. So anytime when it's necessary just to make sure that that collection was done properly and followed through to the end, and we knew that the sample belonged to that patient. So that is the end of the Unit 1, Lecture 1. In the next video, we will get into some of the renal anatomy and renal function.